Our next case, we have a 65-year-old woman is brought to the emergency department by her husband because of increasing confusion, weakness, diarrhea, and vomiting for one day. He reports blurry vision with yellow tint and halos. She has a history of congestive heart failure as well as multiple sclerosis with no exacerbation for 10 years. His current medications include metoprolol, digoxin, furosemide, and spironolactone. His blood pressure is 90/60 and his pulse is 60. Neurologic examination shows no focal findings. There is 1+ pitting edema on both ankles. The remaining of his physical examination is normal. Which of the following most likely precipitate patient's symptoms? A, decreased cardiac output. B, hypokalemia. C, demyelination of the neurons in the CNS. And D, acute viral gastroenteritis. So look at your case, right? We've got a 65-year-old woman, has a history of what? CHF. And is taking, you see that drug in bold? Furosemide, digoxin, right? But look, it's hypotensive, right? And you see here it's got bilateral pitting edema. But blurry vision with yellow tints of halos, that's not good. And now she's confused, weak, diarrhea, and vomit for one day. So what are you thinking? What drug toxicity are we talking about, right? You put it in the chat right now if you know the answer. Now, obviously, we're asking which of the following is most likely precipitated the patient's symptoms, right? This is a very interesting question because you need to understand the mechanism of action of the drug to know how to answer this question. Well, I'm going to simplify it for you. The correct answer is B. So the development of diarrhea, vomiting and abdominal pain, palpitations, blurred visions, headache, and hyperkalemia suggest digital toxicity. So pharmacologically, right, hypokalemia most likely is due to effects of furosemide, which increase the risk of digoxin toxicity by enhancing the affinity for the sodium potassium ATPase pump. So what actually happened in this case is this. The patient has CHF, right? And she took her furosemide, right? And the furosemide blocks the sodium potassium 2 chloride inside the loop of Henle. Well, for one of the side effects of furosemide is called hypokalemia, right? You lose sodium, chloride, and potassium, right? But then it causes hyponatremia, hypochloremia. It can also cause hypokalemia. The problem is when you drop your potassium too low, hypokalemia actually worsens and causes worsening increased risk of digoxin toxicity, right? This is what happened to your patient. This is a very complex case that if you don't know the mechanism of action of digoxin, you're not going to be able to answer this question. All right. So I'm going to explain to you and break it down for you guys. So for this reason, the predisposing factor for this patient going into digoxin toxicity is because of furosemide, right? So any factor that causes hypokalemia, right, such as loop diuretics, thiazide diuretics should be generally avoided in this patient. So let's talk about digoxin pharmacology. So how does DIG work, right? We're going to some pharm right now. Well, digoxin inhibits the sodium potassium ATPase pump, right? Now you might say, where is the pump? Right? It's right here, right on our screen. So this is a cardiac cell, right? And let's go over, let me explain things on a high level for you guys so you can see how this works. So now what you're going to notice is that right here is a beta receptor, is one of your heart cardiac myocytes. And remember, we talk about beta receptors. We said beta receptors have influence under the influence of a beta agonist, norepinephrine, right? Will bind and stimulate beta adrenergic receptor, right? And when they stimulate, they're going to activate adenylyl cyclase, which is going to take ATP and activate cyclic AMP. Cyclic AMP is going to activate protein kinase A, right? Now, protein kinase A has a couple of effects, right? I told you protein kinase A is going to activate a few things, right? Obviously, cyclic AMP gets converted into P right here, right? And this is where the phosphodiesterase 3 inhibitors actually work, right? But let's see. Protein kinase A is going to activate the L-type calcium channels, right, on the membrane. Well, L-type calcium channels, what they do is they bring in calcium, right? They're going to bring calcium from the extracellular component and bring it right inside here. So we can bring more calcium inside the cell. But that increases intracellular calcium. Well, what happens is we got to exchange it for a reason. For calcium to go outside of the cell, sodium has to come inside of the cell. You see that? So there's a sodium calcium channel exchanger right here. And now, once we have a lot of sodium inside the cell, the sodium's got to be pumped out, right? But the sodium potassium ATPase pump has to pump out sodium outside of the cell, all right, and then bring potassium into the cell, right? So that's the sodium ATPase pump. That is what digoxin inhibits. Now, on normal level, right? So when sodium goes out, right, outside the cell, it's got to, when sodium want to come back in, potassium has to be pumped out, right? And then the cycle continues. Now, this calcium is going to activate the ryanodine receptor on the sarcoplasmic reticulum, which is going to cause influx of potassium. So it's a calcium-induced calcium release. So that calcium can get released, and guess what? It's going to go to the actin myosin filaments, right? This is also myosin is going to get activated right here. And then we have the calcium sensitizers, and we have the actin tropomyosin complex right there. So we can get the troponin complex to eventually get contraction of the cardiac myocytes. You see that? Right? That's how we get contractility inside the heart. That's great. Now, here's how digoxin works. Well, digoxin is going to inhibit that sodium potassium ATP. Oh, by the way, when you hear about calcium channel blockers, they block these L-type calcium channels, right? This is where calcium channels block nifedipine, nimodipine, all this. Those are all calcium channel blockers, right? They block this L-type. They block these calcium channels. Now, here's the deal: when we inhibit sodium potassium ATPase, what's going to cause is going to increase intracellular sodium concentration. So the amount of sodium on the outside is going to be much higher, which is going to leading to reduced efficacy of this sodium potassium exchanger, right? This sodium potassium exchanger, because we have too much sodium outside, because now the sodium is trapped outside, right? We normally need the sodium to come in for the calcium to come out, right? So now calcium is trapped inside the cell. Now we increase intracellular calcium. That's good, because somebody has congestive heart failure. They have weakened myocyte. Their heart is weak. It's not able to contract. I don't have the time. I don't have the muscles. Like, I got you. All right. Digoxin, I got you. Right. We're going to increase calcium inside the myocyte. And then in the cardiac myocyte, this leads to increased contractility. That's called a positive inotropic effect. So now we have more calcium inside the cell, activating the sarcoplasmic reticulum, right? Allowing more calcium to go to the cardiac myocytes so we can get more contractility. That's how digoxin works.